Hello and welcome everyone. Today we'll be discussing the esophageal pressure measurement. Esophageal pressure is a proxy which has been extensively validated as an estimate of pleural pressure when it is located within the compliant esophagus near the thoracic center. Now, this is basically done to estimate the transpulmonary pressure because with the esophageal pressure we can estimate the pleural pressure, and we can now calculate the difference between the airway pressure and the pleural pressure, giving us idea about what is the transpulmonary or the distending pressure of the lungs. Now it helps us in assessing the compliance of the lungs and the chest wall, because now we can know the pleural pressure, we can understand what is the elastic recoil of the lung, and from that we can calculate what is the elastic recoil of the chest wall. Monitoring in spontaneously breathing patients quantifies the respiratory muscle effort and helps us in knowing about patient ventilator asynchrony. So the whole idea is to find out the transpulmonary pressure, which will help us in reducing this and reducing the damage that is caused because of ventilator. So the measurement method. Esophageal pressure is measured using a Nasur orogastric catheter with an air-filled balloon connected to a pressure transducer. Some catheters also allow enteral feeding, and placing a esophageal catheter adjacent to a feeding tube does not typically interfere with the measurements. A monitoring setup, ICU ventilator with an embedded auxiliary pressure port, can display the esophageal pressure and airway pressure curves simultaneously. Alternatively, a dedicated device or a standard ICU monitor with proper unit conversions can be used. The balloon placement. The esophageal balloon must be carefully placed in the retrocardiac esophagus, typically 35 to 40 centimeters from the nostril or the lip above the gastroesophageal junction, and then filled with air. So it is always better to make the calculations before you introduce the balloon. So how do we ensure that there is reliable measurement? Confirm balloon placement by ensuring that the esophageal pressure tracings does not resemble the airway waveforms. In passive patients, the esophagus should gradually rise from passive insufflation. In actively breathing patient, negative deflection indicates inspiratory efforts. Cardiac oscillations in esophageal pressure support correct placement. An occlusion test verifies the adequate positioning by comparing the changes in the esophageal pressure and the airway pressure with the delta esophagus by the delta airway ratio 0.8 to 1.2, confirming adequate placement. The next is balloon air volume adjustment. Some group adjust the air volume in the balloon to maximize the change in esophageal pressure between the end inspiration and end expiration. The procedure can also be performed without occlusion maneuvers by observing the tidal variations in the esophageal pressure. So, the direct interpretation of esophageal pressure as pleural pressure. The esophageal pressure is often directly interpreted as the estimate of pleural pressure. But factors like weight of the mediastinum, the compliances of the esophagus, and the balloon can introduce obviously some imperfections. So there is something called the elastance ratio based strategy. Some authors propose estimating the transpulmonary pressure by using the lung to respiratory system elastance ratio. This is the elastance of the lungs. This is the elastance of the respiratory system. This is the plateau pressure minus the esophageal pressure divided by the tidal volume. This is the plateau pressure divided by the tidal volume. So you get a formula like this. This method attempts to account for the pressures used to inflate the lungs and to displace the chest wall. So there are some limitations of the elastance ratio. The elastance ratio based strategy is based on the assumption that the plateau pressure, the pleural pressure is equal to zero at the functional residual capacity, which can be considered questionable. Now, comparative accuracy is that non-clinical studies suggest that directly measured esophageal pressure is more reliable, reflecting the pleural and thus the transpulmonary pressure in the dependent areas of the lungs, while the elastance ratio-based strategy is maybe a better estimate in the non-dependent areas of the lung. So, where do we use this transpulmonary pressure in ARDS? The transpulmonary pressure help in setting the PEEP, finding out the optimal tidal volume for the patient, and to basically establish lung protective ventilation. So how to titrate PEEP based on the transpulmonary pressure? The direct transpulmonary pressure measurements representing the dependent lung regions have been used to titrate PEEP to keeping an end expiratory transpulmonary pressure of around 0 to 2. What this 0 to 2 pressure does, it avoids the collapse of the lungs. So we basically don't want this pressure at the end expiration to go to negative. This prevents the atelic trauma. This approach results in higher PEEP levels, better oxygenation, improved respiratory system compliance in preliminary studies. Are there any RCTs? A trial using this esophageal pressure guided strategy targeting expiratory transpulmonary pressure of 0 to 6 did not show improved outcome compared to more aggressive PEEP FiO2 table based study. Now, the post hoc analysis suggested that the transpulmonary pressure targets may have caused over distension in some patients. Now, inspiratory transpulmonary pressure as a lung stress indicator. We can use this to set PEEP. We can also use it to set the tidal volume. The inspiratory transpulmonary pressure is allowed to reach 20, represents significant lung stress comparable to the total lung capacity in a healthy adult. Post-hoc reanalysis of the large trial indicates that targeting expiratory transpulmonary pressure of -2 to 2 was associated with reduced mortality. Titrating PEEP to achieve slightly positive expiratory transpulmonary pressure may be a potential benefit in obese patients. Now, uh, tidal volume individualization, once the PEEP has been achieved, the target expiratory transpulmonary pressure is reached, the tidal volume can be adjusted to keep the end expiratory tidal volume or the driving pressure within a safe range. Proposed limit is 15 for end expiration and 12 of transpulmonary pressure. The optimal values are needed to be found out through further research. Now, elastance ratio based transpulmonary pressure for the non-dependent lung regions. The elastance ratio based transpulmonary pressure reflects the transpulmonary pressure in the non-dependent lung regions where over distension occurs. This measurement has been used to titrate PEEP to maximal possible value while avoiding over distension. Clinical application in H1N1 ARDS. This strategy helped avoid ECMO in 7 out of 14 patients with H1N1 ARDS. They targeted an elastance ratio of transpulmonary pressure of 25, leading to very high PEEP and plateau pressures often exceeding 30. The applied stress was considered safe as the end inspiratory value was controlled. So since my distending pressure was low, even though I had such high peak pressures and plateau pressures, it did not affect the patient. Now, recommendations for inspiratory transpulmonary pressure. Despite the use of high inspiratory transpulmonary pressure in some strategies, it is recommended to maintain it below 20 for direct measurements and below 25 for elastance ratio based measurements to avoid clinically significant lung injury. Now, obviously, we need further research into the safe range for the transpulmonary pressure, and the delta pulmonary pressure still require clinical studies to find actual targets. Now, the role of esophageal pressure over here is the esophageal pressure is also of value in assisted ventilation. It has been a valued thing to help identify start and end of the inspiratory effort, making it a sensitive tool to detect patient ventilator asynchronies, such as ineffective efforts and reverse triggerings. It helps us in optimizing the ventilator settings. Now, the amplitude decrease in the esophageal pressure during the tidal ventilation is proportional to the intensity of the inspiratory effort. The maximal pressure generated by the inspiratory muscles can be calculated as delta transesophageal pressure plus the component needed to expand the chest wall. Now, used in physiological studies, the esophageal pressure change is monitored during physiological studies to quantify the inspiratory effort through the pressure time product and the work of breathing. For bedside monitoring, the esophageal pressure can be used at the bedside to optimize the level of support and PEEP during assisted ventilation, aiming to keep inspiratory effort within an acceptable range through optimal range still required for further studies. As a bedside tool, it is a well-validated tool to be used at bedside to individualize the mechanical ventilation according to each patient's unique respiratory system characteristics, during which both controlled as well as assisted ventilation. For use in setting the PEEP as well as the tidal volume. And as we have already seen, it helps in reducing the asynchrony. So to summarize, the esophageal pressure monitoring in ARDS, you need to first prepare and check, position the balloon 35 to 40 centimeter from the nostril or the tip of the lip to the end of the balloon. Check the mouth to exclude coiling of the catheter in the posterior oropharynx. Fill the balloon. Now, how much air, that depends on the manufacturer's volume, and inspect the esophageal pressure dressing. What you need to do over here is do a occlusion test. This is the occlusion test. You do an expiratory occlusion. Then you apply a chest compression. That chest compression must result in some kind of airway pressure change as well as esophageal pressure change. This delta airway pressure change and this delta esophageal pressure change, the ratio, if it is around 1, that is 0.8 to 1.2, we can consider that this is good. If not, then reposition the balloon about 1 to 0.5 to 2 centimeter and then recheck. Now, carefully titrate the volume of the air in the balloon to obtain the maximal variation in the esophageal amplitude during the tidal ventilation. So, where you get the maximal amplitude in tidal ventilation, that is the ideal volume for the esophageal balloon. So, the use, as we have already described, to measure the end expiratory transpulmonary pressure, and to keep it around 0 to 2, measure the end inspiratory and try to keep it less than 15, and measure the end inspiratory transpulmonary pressure with the elastance ratio. This will help us in reducing the over distension of the non-dependent part of the lungs. So this is what the diagram shows. Here the blue line indicates the pressure that is applied for the inflation of the lungs, and green indicates the pressure that is applied for the distension of the chest wall. So the ratio helps us in identifying how much pressure we are giving to the lungs and how much pressure we are giving to the chest wall. This strategy is to be used for non-dependent part of the lung, and for PEEP titration we use the direct measurements. Thank you for your patience.